At the time, we'd better begin because I hope that this is going to be a very dynamic session and that there's going to be lots of questions from the audience. I'm David MacKintosh from KAC. I was particularly pleased to get this opportunity to host the Inequality of Access session. How do we achieve a level playing field? Because this really goes to one of the main reasons as to why I got involved with tobacco harm reduction, a background of working with groups which traditionally had been neglected in a variety of ways in terms of access to services, but yet some of the greatest potential in terms of what could be achieved through tobacco harm reduction in terms of personal improvements in health, but also benefits for community and social benefits. Now, there's been I think I see the session really in two parts. I will introduce and you will hear from the participants on the stage and in California at a very, very early hour. And I think we're going to outline some of the barriers that exist and some experiences. But I'm very keen that towards the end of the session, we look at how we can improve the situation and how we can reach out to allies. And there's been some hints and suggestions in some of the earlier sessions on that. But just before I hand over, I think, we often get very hung up on national prevalence rates. In the UK, for men, prevalence rates around 15%. And, generally tracking down, and people would say, well, it's slowly improving. But then we start looking at different communities and groups within that figure. And actually, it's shocking, If we look at a very simple measure, people's employment and educational attainment, we see that something just under a quarter of people in manual occupations in the UK smoke, whereas only 9% do in professional occupations. But that disparity and imbalance is compared to nothing when you start looking at some other populations. Homeless populations, rough sleeping populations, the official figures say 80% of people smoke in these groups. Whereas I can say from when I was working with people who did outreach with those, they couldn't think of anyone they'd ever found who didn't smoke. There's also something like 80% of people entering UK prisons smoke. The world I used to work in, drug treatment, 60% of people entering treatment for opiate issues smoke. So there's, in some communities, smoking's still the norm. And the potential benefits of helping people move on to safer products is enormous in many, many ways. But there are some very significant barriers. And of course, mustn't overlook the fact that another 80% figure, 80% of the world's smokers live in low and middle income countries. And there's big challenges faced there. So that's enough from me for a moment, really, but I will now very briefly introduce the panel. I'm not going to read out all the bio because you've all had access to that, but we have a very distinguished panel. All the doctors, 2 have a clinical background, 2 have research backgrounds. We have Cheryl Olson's joining us from California, and Cheryl does deserve a medal for being up at what I think is not quite 3 o'clock in the morning.
Exactly.
Dr. Michael Kariuki, who's joining us, who is a doctor, a paediatrician by background and working in Kenya. Dr. Dinh Phuong from, Vietnam, who I should, if you get the chance or you haven't seen his short video that's available, should be winning the title for the best titled video from ICU, Intensive Care Unit, to GFN. Describing his journey into tobacco harm reduction. And then my colleague at the end, Dr. Kasia Kowalczyk, who has got tremendous knowledge of NGOs and a lot of background in mental health practices in not only Poland but elsewhere in Eastern Europe and Central Asia. So I will now, I think it's only right, Cheryl, seeing as we got you up so early, that we'll start with you. So a brief sort of overview of how you see the key issues, please.
Oh, the reason I'm here today is because of research that I did on people in custody. And one of the things that I realized, I come from a public health background, and I spent a number of years in academia at Harvard doing research. And I find that most of my colleagues in public health, there's a lot of people are stuck they're in journals, they're among their colleagues, and I think they think in public health that they might be more worldly somehow, but they're really not. I was shocked when I started to do the background research for these studies. Was the research, the studies that were for a specialty vaping product with the lovely name e-cig for inmate. A sheriff named it that. And when we did the research, we asked recently incarcerated people what they liked about this product. The name was the thing that they most liked about it. So they said, it sounds like it's for us. But I was just so struck by the massive need. I mean, first, David, you mentioned in the UK that the smoking rate's around 80%, and that is the rule of thumb I'm hearing in the U.S. prisons as well. When they order these vaping products, they say estimate about 80% of your people are smokers. And when I look at the research that's out there in the literature, it talks about people on the low income health insurance program in the U.S., Medicaid. Smoking rates absolutely stagnant, haven't changed in years. People who have disadvantages, low education, low income, mental or physical health challenges, job challenges, their rates are stagnant, and the more disadvantages, the worse it is. But if you don't know to look in the research literature, you don't know about this. And I think when people look at the bigger picture in the U.S. and they think, oh, smoking rates used to be so high, and now they're so low, and we have nicotine replacement therapies, and why don't these people just quit? There's not an understanding of, look at the data. If they could have quit, they would have quit by now.
Thank you very much. Next, Dr. Phuong.
As you can see in my profile of the GFN, I am the doctor. And my journey from the ICU to the GFN is a long story. I spent very first 12 years in the ICU, where I have to take care of the patient with end-stage COPD, a lot of disease related with the smoking. And at that time, I never pay any minimal attention on the smoking, with smoking consultant, because we are very busy, the patient is very severe, and they still live at the last moment of their life. But after 12 years, I moved into the internal medicine department, and I provide the health care for the patient with the heart disease, lung disease, diabetes, and I recognize the consulting for quit smoking is highest priority for the internist, for the ON doctor. But I reveal 70% of my patients have willing to quit, but 90% of them fail. And even national program of anti-tobacco reach modest achievement. Only 5% of the smoker can quit within the 6 months. And after this, majority of them is relapsed, is smoke again. But in my country, we have a very interesting national program. I think it's the very first harm reduction program in Vietnam. They supply the methadone, a least toxic for the patient abuser of the heroin. Every day, the drug abuser have to come to the health station, receive a methadone, and take it in the supervision of the healthcare worker. And it's very successful. And my question is, why methadone can be used for harm reduction? why HTP cannot be the alternatives for harm reduction for my patient. That's why I do a lot of research. I do a lot of study on the medical paper, and I see a lot of evidence-based proven the HTP can reduce the risk of COPD, can reduce the risk of the cardiovascular disease, and I totally convincing. And that's why, as my duty of the clinician and the lecturer, I try to spreading the idea of harm reduction for my young doctors, for my colleagues, and for my patient. And initially, the perception of the audience is very, very different from the authorities of the Ministry of Health. At Vietnam, the Ministry of Health follow the guidance of the WHO, and they send the warning letter for my house, send a complaining letter for the director of my hospital, and they interfere about my public media talk about the harm reduction. But from the side of my colleagues, my doctors, and my patients, they are very, very highly appreciated. I am the witness, the happiness of my patient cannot quit smoking with a severe heart disease, hypothyroidism, depression, and after transfer into the HTP, she is very, very happy, energetic, happy, not fall into the attack of panic and the anxiety or depression, and her general well-being is big improvement. And from my college, I detect their awareness about the HTP is nearly zero. They are very surprised when I talk about the nicotine is minimum toxic on the body. They still think nicotine is a toxic and never use it. But after I show them the details of the HTP and the minimum toxicity of nicotine, a lot, majority of them ask me how to buy the HTP product. I think that's why, as my duty, I'm not a policy maker, I'm not a researcher, and as the clinician and the medical educator, I think in my country, everything should start from the medical, the health professionals. The patient, the decision of the patient convert from the combusted cigarette into the HTP should starting from the advice of the doctor, not from the company, not from the Ministry of Health. It's my lesson on my daily practice.
Thank you very much for that. And I think we'll be coming back to professional barriers and to explore that a little bit more. Dr. Kariuki, I wonder if you'd like to provide a different clinical perspective.
Yes, thank you. As you heard, I'm a pediatrician, and back in the country, I've been doing this harm reduction work for the last 3 years. And one of the biggest questions that I do get back at home is, what is a pediatrician doing in harm reduction? And my answer is quite straightforward. We want the parents to stop smoking. We want to assist the parents to stop smoking for the benefit of the born and the unborn child. We all know the effects of cigarette smoking on children, and especially the unborn children. Preterm births, very low birth weights. And that is essentially my drive. Because if we have a community that has less smoking rates, if we're able to achieve a stop smoking, or rather no smoking society, then the future generation will be protected. Back at home, we did envision the whole aspect of harm reduction so that we bring it into perspective. And what I did is that I did form an organization called Harm Reduction Society of Kenya. And we have tried to bring on board not only harm reduction in tobacco, but harm reduction in alcohol, in drugs of abuse, in HIV, so that we bring into focus what harm reduction is all about, because we all know these other aspects of harm reduction are well understood. So we want to bring into focus the concept of tobacco harm reduction so that policymakers, Kenyans in general, and more so those who consume these products, combustible cigarettes, to be aware. Our question has always been, despite all the very many efforts that we have had in the country, we all know that smoking rates in lower middle income countries is actually on the rise. And we have had quite a number of interventions which are not as effective. And we have seen other nations achieve very low smoking rates. How can we emulate? What can we borrow from these nations? And it has come to my realization that we have a lot of work on the ground, especially to educate and give more knowledge to our people back at home on the concepts of harm reduction, especially more so tobacco harm reduction, so that we can improve knowledge and the understanding of tobacco harm reduction. One of our key areas is research. We've done research on smokeless tobacco products, which are quite popular back at home. And we are trying to bring into focus that we not only should concentrate on the smoked products, we need to look at these smokeless tobacco products. And the statistics were quite revealing, because a large percentage of our rural population is using these smokeless tobacco products that are homemade with very high carcinogenic components, which are equally as harmful as smoking cigarettes. And we are bringing this on board and telling Kenyans that, hey, look, you're using very high toxic products from tobacco, despite the availability of smokeless, or rather despite the availability of safer alternatives that can assist you to quit smoking. We know we have faced some opposition, but the question has always been, the nicotine replacement therapies, how accessible are they? Let's begin the conversation from there. The pharmacotherapeutics that are out there recommended, how available are they in our setup in the lower socioeconomic status? And how can we increase the reach? How can we educate the people on these safer alternatives, which are being proven to work elsewhere? And it's not an easy journey, but we keep on moving, and we keep on educating our policymakers to try and understand the concept of tobacco harm reduction in the broader aspect of harm reduction. And we believe that the conversation is alive, because there are many fears and misconceptions around safer nicotine products. And we have also realized that the makers of these products have very little concentration efforts in serving the lower socioeconomic status. We don't have some of these makers or proponents of these products coming down to the lower socioeconomic status countries, where the burden of smoking is actually on the rise. And it's a call upon the international community. We have international collaborations so that we can have more research, because we do emphasize that we need evidence-based policies, not just policies out of the whims of politicians and all that. We need, and our policymakers, our countrymen back at home and in Africa will tend to understand more of this research as we try to bring in more healthcare workers into the fold, because we need them as our allies. We need them to understand what are we talking about we do have healthcare workers who smoke. And once they get to learn this, they are always asking, how can we gain, or how can we be assisted to stop smoking? So it's a conversation that we have begun, and we do believe that we will make strides as we continuously try to localize the data. Because once we have local data, once we have local research, it resonates well with the population. And of course, the whole aspect of, oh, this research was not done here. Oh, why are you bringing research from Europe? Why are you bringing research from the US? They will now tend to understand, oh, this research was done locally, and definitely improve knowledge and understanding of THR. Thank you.
Thank you very much. I certainly picked out the importance of knowing your local situation, having good data on the problems that you're facing in the area you're working. And something that I definitely think we need to come back to is the economic aspect, and there's a barrier and affordability to a lot of communities. Kasia, over to you.
So I'm here representing the third sector. With my organization, we are working in, let's call it, general harm reduction in public health. And we support other organizations and institutions in their work with key and vulnerable populations. So the issue of inequality of access to services, this is something that we encounter a lot if in our work, whether we think about opioid substitute treatment, antiretroviral therapy, tuberculosis treatment, or access to mental health services. And I think it's intriguing to note that while a tremendous effort is invested into engaging people in services and ensuring adherence to treatment, so little is done to sort of keep them alive, because we know that key and vulnerable populations are disproportionately affected by smoking. And as I said, I think that one of my key messages would be that we are not utilizing the third sector as much as we should. And there are various reasons why it worked, why the situation looks as follow. And one of them is the way the third sector is being financed. Usually, organizations based on grants, which sort of restrict the activities to what you outline in your program. And also, in general, this area is quite scarce with regards to money, which makes it quite a challenge to carry out comprehensive work. Then the other issue is the capacity of the organizations to focus on the issues that are beyond their primary objectives. Another issue is, and this was raised here a couple of times, is the education. People are lacking of knowledge, but that goes beyond, of course, the third sector. I think that it could be applied to all the people that somehow are involved with healthcare. And it's not only about THR, it's about harm reduction in general. People who are working in health sector oftentimes do not understand the principles. And that is why I also, of course, agree that we should provide education and training. And one of the key group are doctors. And my God, it is so difficult sometimes to collaborate with doctors. So this is why I'm very pleased that I'm here together with two representatives of this group. Then we need to remember also that the third sector used to be sort of the driven force of many changes when we look back into 80s and HIV pandemic. And also is the third sector that usually have the access to difficult to reach out to population. And finally, what I think is that the way the services are being provided is also of high importance. So the services, especially when we think about key and vulnerable population, should be tailored to their unique needs. Of course, they should consider it and take into account the current political situation in country, availability of product, culture, but they should be based on trust and empathy. And again, in the healthcare sector, this is something which, at least in Poland, we are definitely lacking. So the other thing is that I'm a psychologist, I know that every change requires time. And so if you want people to shift, to change into using other products, that requires time, but so does building trust. Yeah. So this is why I think it should also be sort of integrate part of the services. Thank you.
Thank you very much, and a powerful reminder of the potential role of NGOs and voluntary groups. Before I start seeking questions from the audience, there's just one I point out. Well, it is a question really, and it links to two things that I've heard raised there. Professional resistance in a number of areas, and also the need for education and information. And how much do we think that the professional resistance is based purely on a lack of understanding of these new products and, as we've heard, about nicotine? And Cheryl, I'll start with you if I may.
I can't speak to clinicians directly, but I can speak about my public health colleagues. One thing I've noticed, I sometimes will, when I'm talking about these issues, talk about when I used to research on the effects of video game violence on youth. And I noticed that when I would talk to colleagues about that issue some years ago, when there was a rash of shootings in the U.S., which they were attributing to video games, and colleagues would talk about them, and I'd realize that what these researchers and informed people, I would think that they would be informed. I realized they were getting their information not from the research literature, but from what they'd heard colleagues say on coffee breaks, seen in the newspapers, or perhaps saw an article abstract they glanced at. And they would say things like, don't these games cause school shootings, or they got this or that? And I saw the same thing with attitudes towards things like vaping. I recall going to a Harvard Public Health alumni event in San Francisco before COVID, and I think I just started to do the pre-research on this, actually, on this product, and this project that I was going to be doing with people in custody, and I was very excited about the things I was learning. And people were saying things like, oh, vaping, doesn't that cause popcorn lung? Isn't that what addicts kids? Isn't that they had very superficial knowledge, and I realized that people who are often, I think this probably goes for health professionals as well as researchers, those of us who think of ourselves as people who are data-based in our knowledge and understanding, we don't always realize that a lot of what we know doesn't come from data. It's anecdote. And we don't stop to say, wait, how do I know what I know? And if you can find ways to startle people out of that complacency and make them say, oh, wait a minute. I found that the issue of people in custody was a fascinating one. When I talked to people at a later Harvard meeting that I went to, and I was talking to a few young people, in their 20s, 30s, 40s, professionals, about the work of the data I had been collecting at that point. And they were fascinated. And they saw, oh my gosh, this is a really vulnerable population. These are people who are multi-substance users before they went in. They have so many disadvantages. They really need an alternative. They really need something. And it made them just turn around 180 degrees in their view of vaping as something they have to keep away from kids, as something that could be a harm reduction tool. So it's a matter of, I think, of trying to figure out what for a given group can you do to kind of nudge their mind open, give them some kind of example that makes them go, oh, and then at that point they're open to looking at the data and going, wait, maybe there is more to this than I thought.
Thank you. That's a very positive and practical example. Dr. Phuong?
In my country, I think that the acceptance of the medical professionals can be divided into two groups. The first group is the old doctor, my old professor. For a long time, they practice based on the personal habit and personal experience. They may lack the minimal knowledge about statistical evidence-based medicine. That's why it's very hard for me to convince them about the evidence base of the HTP They just said it's tobacco, nicotine is very toxic, and for health, and stop to tell me about this. But for the young doctor who familiar with the evidence-based medicine, when I show them the data of the study on the medical newspaper or journal with the odds ratio, with the chi-square, with the hazard ratio, they are very easy to accept it, and they are very surprised. And I starting to the first lecture about the pharmacology of the nicotine, and it's very. I tell them a very simple example about the not very harmless toxic of nicotine. You should know in the United States, the nicotine patch is an OTC product. You can buy it free without prescription at any supermarket. Why you think any nicotine is a toxin? That's it. Yeah, it depends on the education and the background of the doctor, and especially I think it's the age of the doctor. Generation matter.
Generation matters. I mean, I was very taken when we spoke before today, when you made the point, as you've just repeated, that, you know, nicotine replacement therapy was also seen with a great deal of suspicion, and that's not something we're going to do because it's the nicotine that's dangerous. Dr. Kariuki.
Yes, indeed. The level of knowledge amongst healthcare workers on harm reduction is very, very low. I mean, we did a short survey whereby we found out that of those patients who present to hospital, let's say with other issues, and during the history taking, the patient says, I've been a smoker for the last 10 years. Most clinicians have no idea what do we do next. So they'll end up probably managing what has brought the patient there, be it hypertension or pneumonia. And in as far as assisting this smoker to quit smoking ends there. And there is a huge knowledge gap. When we started telling clinicians that nicotine does not cause cancer, it was a big shock to them. I mean, they always knew that nicotine causes cancer. And these are some of the misinformations that we are trying to fight and educate our healthcare workers, because they form a very key role as allies in harm reduction. And the knowledge gap is huge, beginning with health professionals. And we are trying to do our level best. We have been to several scientific conferences back at home for professional bodies. And we are preaching the same message. It comes as a big shock that the level of misinformation and disinformation amongst healthcare workers is appalling. And we are trying to pass the message that this is the right direction. This is what science is telling us, even as we try to approach our policymakers so that we can have evidence-based policies. So it's a long journey, and we are up to the task.
Kasia.
Well, I believe I will just echo what already has been said, but whenever I have a sort of a contact with either doctors or other groups of people involved in healthcare services, there are like four key arguments that I hear. One is, of course, that the industry. Then there is vaping attracts kids. Then there is that you don't have data. And the fourth one is belief that THR exists not long enough to be able to have like conclusive results. And I just think it's the doctors are sort of the key group that we should focus on. And also it should be sort of like peer-to-peer education, because I'm not sure what else could be done. But I think there is a tremendous role to play by doctors.
Okay, well, one of my plans from today is it will produce a bit of a to-do list. So doctors' education is on the to-do list, and then we can think about that. I'm going to come out to the audience now for for questions, but just an observation that was raised in when you were talking about a lot of healthcare workers smoking. It's my experience that an awful lot of people working in NGOs or frontline services who work with populations that have very high smoking rates also tend to have higher rates of smoking themselves. So that's something there. Right. Oh, right at the back, please. I'll do the translation if you cause any difficult.
Yeah, thank you. Martin Colley from Glasgow in Scotland. I hope that was very clear. Building on the theme that you've just touched on, Dave, and the point you made right at the outset, how does the panel feel that you could best build trust between key stakeholders who have got a different stake in the game, if you like? You know, they've got a different point of interest. So how best can you build trust in stronger collaborations?
Fundamental question, I guess. Have we got any ideas about how we can improve trust?
I don't know. Well, trust, as I said, requires time, but it also requires sort of everyday work. This is how we build trust, yeah? So...
Yes, for the low socioeconomic status, we have identified 5 key barriers on the concept of harm reduction. And one of them is the ability to perceive. The consumers have very low inability to perceive, or the lack of perception of the need for support, and the need for motivation to quit, and the health risks of smoking. So to build the trust, we need to educate the smokers that you need to improve your perception. You need to know that you can be assisted, because the need will be derived from the smoker, that I need these services. And the other biggest barrier we are having is the ability to seek, the lack of knowledge and distrust and misperceptions about cessation support. And that cuts across both with the users, the healthcare workers, the policy makers. There's a lot of distrusts and misperceptions, which can only be removed by enhancing knowledge on harm reduction, on cessation programs that can assist these smokers to quit. And of course, a very unique challenge also as a barrier is ability to reach. We have a huge population living in areas with very few resources, poor social support and mobility. And it's a big challenge to get to this. And of course, very, very important is the ability to pay as a barrier. The issue of cost, the issue of prioritizing it in the to-do list or to-buy list, because there are other competing priorities because of the high cost of these products. And the last one is the ability to engage. We need to engage our political establishment, policy makers, to improve trust and fight the misconceptions and the myths around harm reduction.
To my knowledge, the clear message from the doctor, please, Turkey, quit completely, is very easy. But it just increased the rate of quit smoking 1.3. Yeah, it's not very high. But in our experience, when I spend enough time to explain for my patient, for the consumer about the harm reduction of the HTP, and I should emphasize that HTP is not clear on the risk of the heart disease, but at least it can reduce the risk. The quitting completely is the best. If you cannot, you cannot quit, you can transfer into the HTP. And my willing is not make my patient any confusion and making the fake advertisement for the industry, for their help, for their for the good health, for their willing to reduce the risk in the future. I think it's in my experience is totally convincing for my patients.
Thank you. I know there's another question here, and then we've got a couple along the front, but we start with our friend from Sweden.
I'm Bengt Wiberg, the snus guy called from Sweden. In 2022, I'm going to ask a question first, and then I will just explain why. Is there gender inequality between the use when it comes to user of smokeless tobacco and tobacco-free nicotine pouches? There was a population study done in the UK in 2022 that concluded, which was a mirror of the UK population. It concluded that only 1 out of 5 users of nicotine pouches in the UK were women. 1 year later, I'm very happy, Cheryl takes the initiative to do a survey among US women, asking them why don't they in a higher degree use smokeless oral products. You came to the conclusion there were 4 main deterrents. Could you share the light with the rest of the world? Thank you.
Did you catch
That might be a
Cheryl?
little beyond the scope of what we're covering here right now, but I could use that to segue to a larger point, though, which is the importance of having data for things. The thing that Bengt is referring to, I write most months for the publication Tobacco Reporter, and the reason I do that is because I felt that I don't want to just be preaching to the choir, as they say. I don't want to be just talking to public. I want to build bridges between public health and industry, and so I try to address. Sometimes I'm addressing industry, sometimes I'm addressing public health colleagues when I write. But one of the things I did in sort of a quick and dirty informal survey through email of a U.S. consumer group, Kasia, because I did want to understand why is this not more widely used. And the lack of good data is a real problem that we face, because when I looked at the data on people in custody, for example, I kept seeing different estimates that were old estimates of, it's this many people are tobacco users, this many people. I thought, why don't we have better data on that? How hard is it to go into some facilities and do some, and collect some data? And I think that's something that we need to be thinking about is, are there, and when we do collect those data, we have to be transparent about who funded it. But I think sometimes it is possible to do low-cost things and then use that as what my journalist friends would call a news peg, something to hang the story on and get people's attention about an idea. And if you could look at my Tobacco Reporter piece on the women in smokeless, if you want to know more about what Bengt is talking about.
Thank you. And it's a valuable reminder about not to forget issues around gender, because one of the things, I can't remember which session it was yesterday, was about hidden smoking populations in some countries amongst women who were not admitting, but when the data was collected well, they actually had much higher rates of lipid. Charlie, sorry, the microphone's coming.
Charlie Hamshaw Thomas from the UK. The opponents of harm reduction cite regularly, and the WHO cite this regularly, that there's no need for this because our tobacco and smoking control policies have been working very well. I've heard Stanton Glantz say that. I've heard it from leading opponents in the UK over 10 years ago. We hear from David and from Cheryl there, it's manifestly not working in the hard-to-reach communities. Ergo, don't we need to prioritise the hard-to-reach communities if the whole THR movement is to move forward? And if you agree with that, how do we go about it, i.e. putting it front and centre of the harm reduction movement?
Thank you for that. A very complex but important question. I can see you're biting at the bit there, Kasia.
Of course, I agree with you that, because this is the primary objective of my organization. Of course, definitely we should focus on knowing the death data among key populations and vulnerable populations. The they should be prioritized. But the question is, who exactly cares about vulnerable populations? And well, a few people for organizations, and I just think it's what we could do is just to try to sort of popularize THR among third sector. But it's, as I said, it's a daily work which is mainly based on individual contacts. So this is what we do. We talk to our friends. We try to educate them. Sometimes it works, sometimes it doesn't. But all I've learned so far is that it just takes time.
Yes, indeed. A key observation in the lower middle income countries are the developers and producers of these nicotine replacement therapies, safer nicotine alternatives, have very minimal focus on the vulnerable groups. And this needs to change so that we can have more focus on these vulnerable groups and increase access. Have products that are geared towards assisting these groups. And more importantly, on the ground level, we need local research. People will tend to listen to research that has been localized because it affects them directly, and they are likely to act on it for purposes of evidence-based policies rather than having research done elsewhere, because they will always say, oh, this is not our data. I mean, we don't own it up. And those are two key areas that need to change for the vulnerable groups in the lower middle income countries.
I'm being a bad host, but I can't quite avoid chipping in a little bit myself here. But, you know, there are some examples, and I think sometimes it's highlighting the broad examples than just to the individual. But if you think in the UK, one of the sectors that did adopt tobacco harm reduction quite early, and it helped them deliver their services so much better, was in mental health services, which has been quite a success. But like a lot of THR successes, no one shouts about them very much. And then there's another issue about the direct economic benefits to individuals in countries where THR products are much cheaper than smoking. And Cancer Research UK quite clearly, they're not the loudest cheerleaders for some aspects of THR, but they do highlight the financial benefits to individuals in their piece highlighting THR. So I think there's a lot more we could do around case studies, and I will try to be more restrained about my own inputs.
Can I only quick comment on something you said? Because I'm a researcher, so I appreciate and I value and treasure the data. But when you work with key populations, well, the data are important, but this is not something you work with. I don't think people that we work with are looking forward to read the data. It's quite complex. It's even difficult for the researchers. So what I think is helpful is this individual personal contact, personal stories, personal examples. This is what works.
Well,
I think stories are what change people's minds.
Touching on a few themes already mentioned, panelists may be aware of a model known as contingency management, whereby people are offered small financial incentives to reduce risky drug use. Evidence, I believe, has supported it with groups of people who use methamphetamine in the United States. And more recently, we've seen it rolled out at a council-level pilot in the UK. And if you quit smoking during pregnancy, very much including if you switch to safer products, then you receive vouchers as a reward. Obviously, there are upfront costs to such programs, but potential huge healthcare savings as well as many other larger benefits. So my question to anyone who wants it is, do you think that this model has the potential to be scaled up and then targeted towards marginalized, vulnerable communities?
Okay, so that's about incentivizing people switching. Cheryl?
Yeah, I'd like to make a bit of a related point, because I think that's more of a Kasia question. since you're more on the ground with these things. But I know talking to, I think this is a great point for doing cross-profession collaborations. We talk about trust building. The economists often have some great data, and I think sometimes they're more logically driven than some of the advocates. And I interviewed for an article I wrote a gentleman named Michael Pesco, who has all of the right credentials, an academic who came through the National Institutes of Health or CDC training, and very respectable, publishes in respectable journals. But he is publishing things that will show, it is better to give rural teenage girls who are pregnant access to vaping because otherwise they'll smoke. All kinds of. That's just a little study because it has not been. But he has study after study that is where the data are very logical, very pro-harm reduction, flying in the face of things. And I think sometimes you can, if you find yourself blocked with your own profession, sometimes you can go to another one, make an end run, and then bring their data back and say, hey, did you know about this? Because I'm absolutely 100% agree with Kasia that it is stories, anecdotes that get people to listen to the data. That if you start with data, they almost never listen to you.
Thank you. Anyone else on the panel views on incentivizing people?
I know what.
Oh.
So I did a few studies, pilot studies using incentives with Māori Indigenous pregnant women in New Zealand. So we tried vouchers. Another thing that we tried was sort of, I don't know if you have you join up to a program and there's like a gift catalog. You have a card, the more points you get, and you can pick your gift from the catalog. We did that instead of vouchers. Some women are in relationships where they have a partner that controls the money, or if you give vouchers, say for groceries, it'll be taken off them. So it was interesting. They liked the booklet that had, a care package or a camera, or, we just had a range of things that they actually really liked that because they were things that their male partner weren't going to take. So there's things to think about like that. But definitely the vouchers worked. The program ended up being rolled out by the government, and Māori Health and other health cessation services got to offer incentives. So definitely got picked up in New Zealand. I was working with Linda Bald at that time on one of those studies, and they were doing it in the UK as well. And there was some similar pilot trials among Aboriginal women in Australia. One of their voucher systems were for whiteware. What the women wanted was to be able to buy a new fridge or a new washing machine. So you can, maybe even put together a program like that where you have stores sponsor and provide, product. So
can I ask you about the sort of sustainability of such? Because I would be very eager to use them, but I'm just curious what happens while the project is over, finished, whether it still works.
So do you mean in the follow-up if they stay stopped? Well, obviously these pilot projects are just a limited run, so 12 weeks or something like that. I did get to evaluate one of the hospitals that use the system. When you're working with hospitals, but you're supposed to be doing kind of evaluation or research, the data collection is not necessarily always good. You have kind of a selection bias, and they don't keep track of the ones that don't join the program. So there's those that are referred, and then they don't get counted in. So it is good to have robust science done rather than just sort of an evaluation. Yeah, I'm pretty sure the evidence overall and the Cochrane review, shows that overall incentives do work. Interestingly, among Aboriginal people, looking at incentives for pregnant women at a committee, a kind of a consensus summit on it, they decided no, it wasn't appropriate culturally. There was something offensive about it, they felt, paying women to stop smoking while pregnant. So there's also cultural factors to take into account.
Thank you, Marua. I say, yeah, good points to know the communities you're working with and targeting, and also good practical examples of things that have worked. I'm very keen that we don't forget to start thinking about the allies, and we've touched on it. Is there anyone in the audience who's got any ideas about the groups that we should be seeking to engage to promote THR? And wave your arms vigorously, because I am slowly going blind in front of this light here. Fiona.
Thank you. This is a fantastic panel. Thank you. Oh, it's just in case you couldn't hear me. I've really enjoyed the work that Dr. Olson's been talking about, but certainly thinking about that question, it's looking at some of those organisations, long-running organisations that help vulnerable communities and people from low socioeconomic organisations. And I'm thinking there's St. Vincent's, there's St. Vincent's John de Paul, the different charity organisations that are out there, even with their food, the sort of food centres and things like this, because we know from Marawa's work that if we can convince particularly some women who are smoking that this can put more food on the table, and I certainly think that those organisations providing that type of basic essentials to people experiencing poverty in our communities, they would be a group that I haven't actually considered, and I'm certainly going to go home and think about them.
Thank you very much. Charlie at the front. Sorry, at the front.
Business people. Philanthropic business leaders.
I'll be after your diary and yeah, but it's a good point, because funding for this is complicated.
Is funding, and why?
And that's a very good point. And if anyone in here does know any billionaire philanthropists who would be interested in this area, feel free to approach me at the end of the session. Marua.
Thank you. An interesting development in New Zealand, there's a group forming to end all prohibition of all substances. And they've seen me tweeting about my concern about the vaping regulation, the smoked tobacco product regulation, which is really going towards prohibition of all nicotine and tobacco use in New Zealand. And so I got invited to a meeting they were having. So we shouldn't forget the drug harm reduction sector, and Nick talked about it previously. It can be difficult. There is some resistance. I think there is some potential fear of bringing the hate of public health down on them for adding tobacco into it. But there are groups that are against prohibition, and that is what many of our for the harm-reduced products are facing prohibition, and they would see this as this is part of the slippery slope. New substances keep being added to the list of substances to be prohibited, and so we have something in common with them.
Thanks. That's an interesting point on sort of policy and political alliances. Anyone else out there? I would also like to do a little bit more on perhaps the economic barriers to people adopting THR. And I don't know if anyone on the panel would like to points on that, but in mentioned in the UK, once you've found the kit that works for you, vaping is cheaper. There's an initial barrier there, but obviously in some countries, particularly where smoking is relatively much cheaper, there's a huge disincentive, if you like, or a huge barrier to get over by, you're being asked to invest in a THR product that no one's using around you. And I wonder if any thoughts about how that can be addressed.
Well, while you're thinking, that's something that I've seen in research I was just doing with older smokers. I guess I did a qualitative study on smokers in their 60s and 70s primarily. And they're using these older cigarette-like products because they like something that looks and feels like a cigarette, and they are incredibly price sensitive. They will, sometimes shipping costs will be enough to deter them from going for something. And that's a side point with that is that I think we need to look for who are sympathetic people. And so if people aren't sympathetic to the needs of drug users, others who they think brought it on themselves, if you're looking at people who are now, for example, in their 60s and 70s, who started smoking at a time when everyone around them smoked, even on TV, as they were saying. And they were once the vulnerable youth who were hooked, and they're still smoking. And don't we care about them who are immediately at risk of disease and death from the smoking they're doing today? And that's a way you can look at, okay, these people are out there and they need an affordable alternative. And if you find that for them, they will switch.
I see that's a really helpful reminder of the older smokers. And it also reminds me of quite an early ally in the UK around switching to vaping was the fire brigade. Because although we currently have lots of stories about disposable cigarettes setting fire to bins and things, they don't cause as many house fires and fire fatalities as smoking did, particularly amongst the older population. We are getting towards the end. I am in a moment going to pass over to the panel for their last thoughts on particularly the things we can do to overcome the barriers. And as I say, the identifying allies, we've got a few on the list. If there's any other allies you think we're missing, now's a good time to put your hand up and share. I don't think I'm seeing any hands up in the audience at the moment. So, we should have given you a microphone. You could have, that's a good thing.
Just on the cost. So interesting, obviously there's different arguments for the banning of disposables, but disposables are like, they're cheaper. And so I think in New Zealand it is improving access for groups who previously found the other devices inaccessible, or they were worried about investing in something because if it doesn't work for them, then they've lost the money that would have bought that packet of cigarettes or 2 packets of cigarettes for that week. And it's interesting that disposables are now coming under heavy attack because they are lower priced, it's a lower entry point for people, and it's giving access to lower income groups, older people, and they're quite efficient devices.
Yeah, I think the simplicity of use is a huge, huge advantage. Okay, I'm going to go across. We'll end with you, Cheryl. So we'll go across from my right. Your number one, and if you've got two things you think we should do to help overcome the barriers and improve understanding, or allies that we should be targeting.
In my experience and the journey to harm reduction concept, I got a lot of obstacles, and the first thing is the cost of the HTP product. In Vietnam, the price of the cigarette is incredibly cheap, just $1 for one package of cigarette, and very easy to buy at every corner of the street and even the supermarket. And the cost of the HTP a pack of the IQOS, the HIS, is maybe 10 times or 20 times of the package of combustible cigarette. That's why I got some difficult to convince the patient switch into the HTP, because they complain with me, hi doc, the price is too high, I cannot afford it. But my best way to handle it is high. I agree with you, but at least it's cheaper than the cost of stenting, coronary angiography. Yeah. And I think in the future, the tax of the combusted cigarette should be higher in our country to make a smaller gap between the HTP product and the cigarette.
I think that's a really good point, that the safer products should always be cheaper than the most dangerous product. Thank you. Dr. Kariuki.
Yes, indeed. The policies back at home and generally in Africa, East, Central, Sub-Saharan Africa, we in the process of developing some of these nicotine policies. For example, it's only last month that the Kenyan Parliament, that is the Senate, introduced a notice of motion to have nicotine policy regulations. And that is a very good opportunity because it will involve public participation where we will present our views and bring in the concept of harm reduction, simply because even back in Kenya, the Tobacco Control Act does not define what tobacco control is. It's an argument that we have tried to reach out. And when you talk to the policymakers, they say, yes, we have drafted our Tobacco Control Act from WHO's FCTC. But when you show them that the FCTC has clearly defined what tobacco control is, and we are missing that definition in our own local Tobacco Control Act, then they start saying, oh yes, there is a point here, because FCTC defines tobacco control as a range of supply, demand, and harm reduction strategies. And it was like a deliberate attempt to omit that particular statement from the local Kenyan Tobacco Control Act. So it's an opportunity to begin with the legal and regulatory frameworks that bring in the concept of harm reduction, even as we continue the debate of harm reduction. And at the policy level, that's exactly what we are trying to do, so that we can have some nicotine regulations and look forward to probably even have a nicotine act by itself. And as part of the solutions to overcome these barriers, we need products that are approachable, acceptable, available, affordable, and appropriate for the low socioeconomic status groups.
Thank you very much. Yeah, that's key points, and also the importance of appropriate legislation. Kasia.
Well, I would say utilize the potential of the third sector. Yeah, there is a power there. And one more thought on our potential allies. I would say anyone who has a direct contact, any healthcare service and a healthcare group who has a direct contact with key and vulnerable populations. And one that comes to my mind is, for example, social workers. I'm taking part in a project and we are working in Central Asia, in 3 out of 5 Central Asian countries, when we are helping to build curriculum for social workers. And social work is a very specific area, and of course we know that it differs around the world, but there is a potential there. And if THR would be included into curriculum, that would be just fantastic.
Excellent. And Cheryl, over to you.
Right. There's so many good points here. I think that my colleagues here on the panel have made, things like make sure that there are shared common assumptions, that people understand it's not the nicotine giving you cancer. Make sure that you understand, if you can find an authority or an individual who people listen to and agree on, that is a framework or a group or a person that we should listen to as a way to open minds. Looking for overlooked groups, I noticed in the U.S. that nurses are a group that I would love to target with reduced harm information. The reason I'm not with you in Warsaw is my spouse has been extremely ill and spent months in hospital. And when I speak to the nurses who come in to work with him, sometimes I show them little tobacco-free nicotine pouches, other things that I picked up at previous conferences. They've never seen these before. They didn't know that they existed. And I think we need to find people who can infiltrate and get around some of the barriers, so that then perhaps the more senior people who are more resistant are forced to address, hey, the patients, the staff are asking about these things. What is this? We need to educate ourselves about it.
Thank you very much. So I think we've got some clear things that we can all do there. We should all go out and try to engage with different organisations or individuals that we don't normally work with, and start from that. And I think, focusing on the communities which have very high smoking rates, I think there's an awful lot of opportunity that we should be taking advantage of there, because the potential gains are enormous. I am aware that your lunch will be outside, so I'm not going to keep you any longer. But I would please ask you to join me in thanking the panel, especially people who were getting up at something like 2 o'clock in the morning to join us. Yeah.